This conference will now be recorded.
Well, good morning, everybody, and thank you for joining us today. We're here to introduce our newest rheumatologist at Lurie Children's, Dr. Pooja Patel. And I'd just like everyone to know that we are recording this session. And if you have colleagues that are unable to attend here today, I will be sending this link out to you and to them so they can view the session on their own time. So without any further ado, I'd like to send this over to the practice manager for rheumatology, Segun. Segun, go ahead and take it away.
Yes, good morning, everyone. Again, thanks for joining this morning. My name is Segun Ogunlaye. I'm the division administrator for the division of rheumatology, and it's with great pleasure that I'm able to, or honored with the task of introducing Dr. Pooja Patel this morning. She came to us from Texas Children's Hospital, where she completed her fellowship. She completed her residency at the University of South Carolina Medical Center. She will be seeing patients, or she is actually seeing patients at the main hospital downtown. She's seeing patients at our Clacton-Deming location in Lincoln Park. She sees patients at Arlington Heights and at Northbrook. In the short time that Dr. Patel has been here, she's helping us and leading many different initiatives. So she's been a great pleasure to work with, and I hope that you all enjoy this talk. And I want to encourage you all to please use the chat function for questions and things like that. So without further ado, Dr. Patel.
Thank you, Segun. I'm going to share my screen here. And is everyone able to see and hear?
Yes.
Yes.
Okay, so today we'll be talking about laboratory evaluation in children with possible rheumatic disease. So some of the objectives I have are to understand the different laboratory techniques that are used, discuss the clinical significance and utility of some of the various tests that we order, understand how to interpret the testing, and so we can discuss how to provide counseling to families. So first talk about the ANA. What do you mean it's not lupus? The titer is 1 to 160. So what does this really mean? What is an ANA? These are antibodies against proteins in the nucleus of the cell. Usually we use FANA and we use microscopy, fluorescent anti-nuclear antibody test. This ANA test is measured in titers. It is very non-specific, but highly sensitive for lupus. We'll go over that in just a little bit. And can be seen in several different disease states. So JIA, lupus, autoimmune thyroid disease, ITP, infections, and MS. I'm going to quickly just go through the pattern, not that this is going to be, this gets published when we order labs and we get a report. This nice picture doesn't get published, but the pattern does. So clockwise, starting from the left upper corner, this is a peripheral pattern where the staining is on the periphery. This is a homogeneous pattern where the entire part is stained. And down here we have the nuclear pattern where the nucleus is stained, and it's a speckled pattern where we, this is a little bit hard to tell, but there's a lot of different like speckled areas here. So the types of ANA detection. I'm not going to go through this in significant detail, but really there's different ways of detecting an ANA. Some are more sensitive than others, and that's why there are certain labs that rheumatologists like to send their ANAs to. So indirect immunofluorescence is the most widely used assay. It uses HEP cells as a substrate. HEP cells have large nuclei and they contain all clinically important autoantigens. So you can see why this may be an important use for this test. IFA really works in a way where cells are grown on and subsequently fixed glass slides. They're permeable with the solvent and they're overlaid with a diluted patient serum. And after the incubation, the slides are washed And you remove any non-adherent immunoglobulins and other serum proteins, and the cells that are incubated with fluorescein conjugated antibodies, which are directed against human IgG, these cells are then present. And you end up detecting often dilution, so 1 to 40, 1 to 160, and so on. And they're serially diluted and retested. And that is how some patients will end up having a very, they'll have greater than 2560. The other way is solid phase assay, which are ELISAs, and fluorescent microscope assays and immunoline assays. So what does the titer actually mean? So 95% of those with lupus will have a positive test, so it's sensitive, but it's not very specific. So that said, only about 11 to 13 people with a positive ANA test have lupus, and up to 30% of completely healthy people have a positive ANA. So a lot of healthy people have positive ANAs, and in children, depending on the study, there are about 15 to 30% of healthy children that have a positive ANA and have no sign of autoimmune disease. And so a positive ANA does not automatically translate into a diagnosis of lupus or any other autoimmune or connective tissue disease. It really, this is a very important point to kind of provide reassurance to families regarding the ANA positive test until they're able to see their rheumatologist. And going back to this slide, actually, what I quoted was off of one of studies, but if you actually look at data from Mexico, actually indicates that close to 100% of the population, and this is all adult data, have some degree of ANA positivity. So ANA really varies in ethnicity and geographically as well. So ANA titers in children are commonly ordered and often positive. Less than 1 to 160 has a negative predictive value for lupus. Depending on the lab that you order, it might not even flag as positive until 1 to 40 or 1 to 80. And then 1080 is not actually a titer that is published. It's a raw value. But studies have shown that greater than or equal to 1 to 1080 has a positive predictive value for lupus. There's really no diagnostic utility in either making or excluding the diagnosis of JIA. They have tried to look at a lot of studies with ANA positivity and JIA, and it really doesn't help make the diagnosis or exclude the diagnosis. So I often tell patients and families that if you have a positive ANA, it doesn't mean you have lupus or JIA. And if you have a negative ANA, it doesn't mean that you don't have lupus or you don't have JIA. Really, it's used and it tells us things like prognosis and prognostic factors. So it helps us. If there's a positive test, if a positive ANA and it's a patient with oligoarticular JIA, we think that patients with a positive ANA have a higher likelihood of having uveitis or eye inflammation. We'll go on next to the rheumatoid factor. So how can you have arthritis if this is negative? Very similar to what I just talked about with ANA, you can have arthritis and have a negative rheumatoid factor, and that we see a lot in children with oligoarticular arthritis or rheumatoid factor negative polyarthritis. What is a rheumatoid factor? You measure antibodies to the FC portion of the IgG immunoglobulin, and it's usually reported as positive or negative. There's not really a great titer that reports out with the rheumatoid factor. There may be a number, and most labs publish a positive over like 14. In adults, an anti-CCP antibody is also often checked, but not proven to be as useful in children, though we do order a CCP antibody when we have a positive rheumatoid factor. And there's more data in polyarticular disease than in oligoarticular disease. And when I talk about polyarticular versus oligoarticular, I'm really just talking about the number of joints involved. So in oligoarticular, there's 4 or less joints involved. And oligo, there are more than that. So you interpret the rheumatoid factor test. It's really used by rheumatologists for prognosis, and laboratory studies should be ordered to rule out other diagnoses. Rheumatoid positive arthritis may actually take longer to achieve remission. And so that's what I mean by how this test is used as a prognostic marker. We see a lot of rheumatoid factor positive children who have polyarthritis, who have erosive disease that takes longer to control. And so it helps us with kind of management. If you really have a patient who has a lot of erosions, it might be worth trying a more aggressive treatment up front. So inflammatory markers, what causes the inflammation? I think we know that these are really non-specific, and we get inflammatory markers when we're concerned about infection, inflammatory conditions, autoimmune issues. So I wanted to talk a little bit about CRP detection because I find this really interesting. So calcium precipitation due to reaction of C polysaccharide from strep pneumo is what you're measuring. The patient's serum is incubated with anti-CRP antibody. This antigen-antibody complex is detected with specific peroxidase conjugated antibodies. And so it's very nonspecific, and you actually end up measuring these precipitates that come down. Why is this useful? It's an acute phase protein produced in the liver. Interleukin 6 is the main mediator for synthesis. Within 6 hours of acute inflammation, the level starts to rise. So it's very acute. The half-life is about 24 hours. So it very accurately parallels the activity of inflammatory processes or infections. But we don't like to use this for long-term, to follow long-term. So someone in, say, osteomyelitis, a SED rate would be better to follow long-term. ESR detection, so otherwise known as erythrocyte sedimentation rate or SED rate. You have anticoagulated blood is drawn up in a tube and left in a vertical position for about 1 hour. The red cells separate and settle from the plasma, as you can see in this picture. The distance between the red blood cells actually fall in 1 hour is measured. This is mainly influenced by plasma proteins, including fibrinogen, IgM, and alpha-2 macroglobulin. So after giving IVIG, we say don't check the SED rate because it's going to be falsely elevated. So, if you give someone immunoglobulins, which will increase the ESR, then it's really going to be not as accurate. Why is the SED rate useful? It takes about 1 hour, so it's a very quick test, and it's easy to use for long-term follow-up. So for us, when we have patients who have systemic inflammation, autoinflammatory diseases, vasculitis, we follow SED rates over time to see how their disease is doing. A CRP for us at that point is not very useful just because CRP is so acute. Disadvantages. It does react slowly, so you may have some clinical improvement and still have a very positive SED rate. So CRP is actually more useful when you're looking day to day, and SED rates are more useful when you're looking almost like week to week. Increases with age, anemia, obesity, and female gender, and it's falsely elevated after giving IVIG. So a D-dimer is another marker that we actually measure as an inflammatory marker for children who have vasculitis. So it measures the amount of a protein, fibrin D-dimer, in the blood. Fibrin D-dimer is produced when fibrin is degraded in the vascular system. Fibrin is a fibrous protein involved in the clotting of blood. We serially measure D-dimers in children who have HSP, Kawasaki disease, or any other vasculitis or vasculopathy. Vasculopathy is really a disease affecting the blood vessel, and vasculitis is inflammation of the vessel. So we do use D-dimer very often, especially if they're not anticoagulated and there's no concern for an acute thrombotic event. So values of greater than 2 indicate a higher likelihood of coagulopathy and endothelial damage. The next test is of ferritin. So why is this important for inflammatory conditions? It is also an acute phase reactant, helps control damage that was potentially induced by free radicals, is an interleukin-1 mediated response, and it's associated with a number of conditions like macrophage activation syndrome, systemic GIA, or catastrophic antiphospholipid antibody syndrome, but also things like spherocytosis and septic shock. So additional testing to consider is really getting LFTs when you have a patient who you feel like may have something autoimmune, a serum creatinine to look at their kidney function, a urine with micro to really look to see if there's blood, if there's protein, and if there's any cellular casts that are present. Of course, whenever there's a kid who potentially has any infectious symptoms that preceded their state, infection testing is important, especially strep and Lyme. We see Lyme arthritis actually pretty often. And so if there is a high clinical suspicion of Lyme, always check Lyme titers. And then a vitamin D level, especially here in the north, I've realized that a lot of kids are actually deficient in vitamin D. So some take-home points is, so do not use the ANA to screen for autoimmune disease. It's not a great screen. Routine screening increases the likelihood of a positive result with an unclear clinical significance and really causes families to really be worried until they actually see the rheumatologist. And fortunately, we don't have a very long wait list at this time, but some institutions do. And so I do remember back from my training, it could take months to get patients in, and from the time they get their testing that's positive to the time they see the rheumatologist, they've already looked up everything on Dr. Google and are quite worried. So history and physical exam are very important and should guide your initial workup. Initial testing should always include a CBC with differential and inflammatory markers, plus or minus infectious testing based on their symptoms and kind of what you feel may be going on, urine studies, and a CMP. And then I don't say never order an ANA, but obtain an ANA really as an adjunct to help confirm something you're already considering. And an extended ANA panel, so the other antibodies, which are called ENAs, may also be helpful when there's a concern for something like lupus or Sjogren's based on clinical symptoms. So by limiting ANA testing, you can really avoid needless venipuncture pain, unnecessary referrals, extra medical expenses, and most importantly, significant parental anxiety. But all that being said, if there's any questions regarding any of the testing or a positive ANA that comes up, feel free to call us. We're always available to answer questions. Feel free to send us messages through Epic or email. I have my email and my office phone number listed, and we're happy to kind of run through any lab testing and patient scenarios. So I'll kind of open it up to questions for anyone that has any questions.
Yeah, Dr. Patel, thank you so much. Dr. Duong has asked, how long after IVIG given can you check ESR?
I usually say 30 days. So depending, the half-life of IVIG is very long, and so we usually like to check titers about 28 to 30 days following IVIG. And at that point, reasonably, you've probably bound all of the immunoglobulin that you're going to bind.
Great. You know, since we have a short room here, if anybody else has questions, you can feel free to unmute yourself and ask Dr. Patel a question.
Thanks, Dave Dobkin here. They're clearly right. There's a lot of people are doing too many ANAs. So if you get back to 1 to 80 or even a 1 to 160, and there's no other signs of lupus, and someone ordered it for whatever reason, it's okay to reassure them, or in most cases, if there's no other lupus signs?
Exactly. So, if there's no other symptoms like rashes and fevers and fatigue, hair loss, constitutional symptoms, then less concerning for lupus. If there's no like swollen joint, warm joint stiffness, then there's less concern for arthritis. And so you can kind of give them return criteria, kind of things to look out for. If it ends up being arthritis or lupus, it's definitely not going to go away. So that's definitely reasonable if it's like a 1 to 80. The other thing to consider is also, I see a lot of referrals for positive ANA and hypermobility. So kids who have a lot of joint pain. So sometimes what I actually do is when I don't see arthritis on exam, or I don't get a clinical history of arthritis, I'll send them off to physical therapy. And in very many cases, their joint pain will improve, and I just counsel them on a positive ANA.
So follow up to that, let's say you get a 1 to 320 or 1 to 640. So it's in between that 1 to 60 that you mentioned, 1 to 160. But if you get it medium, and are those just straight referrals, or how do you coach that one?
Yeah, I would probably send a referral. Autoimmune thyroid disease, MS, ITP, a lot of those and other autoimmune issues can cause positive ANAs, and we see that very routinely. So I'll see positive ANAs with patients who have IBD, celiac disease, thyroid disease, and even type 1 diabetes, which are all autoimmune conditions. And so it's nice to kind of have them plugged in with rheumatology. We counsel them on having a little bit higher ANA. And if it's anything like 640 or above, I do follow them yearly in the chance that they develop an autoimmune issue.
Thank you.
Well, Dr. Patel, this has been great. And I know I can speak for a lot of the practices surrounding the Arlington Heights area that are on the line right now, that they're very excited that you are here with us, and glad you are on board. You'll be seeing patients at the main hospital, Lincoln Park, Arlington Heights, and Northbrook. The question I have for you, Dr. Patel, is when you mentioned lab testing, are you doing most of your testing at Northbrook or the main hospital, or can we do the testing for some of these at Arlington Heights and Lincoln Park?
So we do have lab testing at the main hospital, Lincoln Park, Arlington Heights, and Northbrook. I think the labs are open for longer hours at the main hospital and Lincoln Park and Northbrook, but Arlington Heights does have a fully functioning lab. Imaging will be available at the main hospital, Lincoln Park, and Northbrook. MRI is available at Northbrook and the main hospital. Imaging is through Northwest Community when it's done in Arlington Heights, which can be done. It's just a little bit more difficult. But I definitely have done imaging at Arlington Heights through Northwest Community.
Excellent, excellent. And then what days will you be in Arlington Heights?
So I'm usually there the middle of the month, 1 day a week. I think it's the second Friday of the month.
Okay. And if our folks online here want to make an appointment with you directly, they can either go send you an email or go through Epic.
Yes, that or my office. So the direct number, and I think you can share
right
the
here
screen.
On the screen.
Yes, I think my screen is currently shared.
Yeah. So if you want to, she's on Rapid Connect. You could also reach her at 312-227-6270. Email at poojapatel@luriechildrens.org, and Rapid Connect or Epic staff message. So she is readily available for you all. And again, I want to thank everybody who came on the line today and joined us. And if you can just tell your colleagues that I'll be sending out this meeting, the video link to everybody so they can see it on their own time. And I just want to remind everybody to save the date for February 3rd at noon, where the Lurie Children's Physician Liaisons will be putting on our quarterly practice management symposium. And there we'll be talking about our new digital front door and we will have our director of Kids Doc speaking. So it's going to be a very well worth attended meeting that you're going to get a lot of answers for you regarding access to the hospital. So we are looking forward to that on February 3rd. But I just once again thank everybody for joining us today, and Happy New Year, and we'll be talking to you all soon.
Thanks, everyone. Take care.
Thank you, Ted.
Be well, everybody.